Hi, I'm Dr. Mike DiTolla, and I'd like to welcome you to this edition of Inside Dentistry's Product Talk. We are on location today in Des Moines, Iowa, in the office of Dr. Bob Margeas. Bob is an adjunct professor of operative dentistry at the University of Iowa. He maintains a private practice here in Des Moines, and he's also an Inside Dentistry board member. In fact, he's Inside Dentistry's editor-in-chief, and I'm here today to talk to Bob about Lumineers and the art technique from DenMat Laboratories. Bob, thank you so much for having us here and letting us come into your office.
Welcome.
You and I are roughly the same age. You can kind of tell by our haircuts. And when I first think of porcelain veneers, I associate that with DenMat because they introduced, basically, for all intents and purposes, the veneer to the world back in 1984. Was that kind of your first introduction to porcelain veneers as well?
Absolutely. It really was. And with Bob Nixon, that was doing a lot of lecturing back then, that's what really got me started.
Right. And then in 2004, they introduced Lumineers. And at the same time, they did something really unique. They began their direct-to-consumer marketing program, which we don't see that often in dentistry. So I think any dentist who has had a patient come in and ask about porcelain veneers owes a thank you to DenMat for taking those ads out on the back page of People magazine and things like that. As a company, they've always been very focused on conservative dentistry, this concept of the no prep veneer or the minimally prep veneer. How does that type of conservatism fit into how you like to do aesthetic dentistry?
You know, early on, I learned that obviously conservative dentistry was the best because porcelain veneer success was really preserving enamel. So from the day one, I was always very conservative. Not necessarily prepless, but prep-less.
I like that.
Yeah. And I was able to be successful. My veneers never popped off. What would I see over 15, 20 years? Maybe a little recession, some staining, and maybe a chip here or there, but never a debond.
Well, and that's the thing. Every dentist knows that bonding to enamel, we love that. You know, it starts right when you get out of dental school. You etch the whole facial surface of a central, that frosty look that we get to see. You know that's going to be a successful bond compared to dentin, where there's a little more work, involved to get it to stay on. So you're right. You get rid of a lot of the possibility of debonds by bonding to enamel, and at the same time, you reduce post-operative sensitivity to almost zero, don't you?
Yeah, absolutely. And if I ever had a veneer come off, the cement was always in the veneer. It was an adhesive, failure because I had maybe over-prepped and I didn't preserve a lot of the enamel.
Well, I know you got a chance recently to do a veneer case with the DenMat Laboratory, and you were nice enough to put it up here on the screen for me. Why don't you walk me through this case?
Yeah, this was a gentleman who had gone through orthodontics. He had a severe wear case. He was end to end. It was just like impossible to put veneers on or even restorative dentistry. And so I had him go through ortho. And so what the orthodontist did was really change the incisal edge. They intruded the teeth to get the teeth out of the way. So what I'm going to do is I'm going to lengthen the teeth with porcelain, unsupported porcelain, 2 to 3 millimeters. When bonded to enamel, very, very strong, do not debond. And so you can see here we now have room for the porcelain, and in a situation like this is basically going to be additive on the incisal edge.
Okay.
And I'm not going to have to reduce the enamel very much.
Right. So without the help from that orthodontist, you would have had to open the bite maybe with some posterior restorations.
Correct.
To get enough room to do this. And so that was really great that he was willing to go through orthodontic treatment before. That really sets you up for success here.
Because sometimes patients don't go through ortho.
Right.
And they have teeth that are out of alignment. In the old days, if you put a reduction guide on or a reduction drill, and all of a sudden you only reduce a 0.5 millimeter, in those areas that were out too far, you're obviously going to have an over-contoured restoration.
Exactly. It wasn't enough reduction in those areas.
Exactly. And so what we did is we had a wax up done.
Okay.
And so I worked with the technician. They formulated the wax up. We went back and forth, decided what we wanted to do. Once that wax up was done, we had a putty matrix that they had sent with the case. I placed some bisacryl in the putty matrix, placed it over his teeth, and then I could actually see the final result of what we want to accomplish, where I needed to prepare the incisal edge, and I could prep right through the provisional, maintaining enamel on virtually 100% of the tooth.
It's nice to hear you say you were actually able to talk to the technician themselves. One of the things that the DenMat Lab prides themselves on is this concierge type service, so that if you have a question and you want to ask the technician something, or you want to express a concern that you or the patient have, it's very easy for you to get in contact with them and have this type of conversation. Is this something you were able to do throughout this case?
Yeah, I was very impressed with that because you worked with the same technician throughout the case. A lot of times you call laboratories and you have a difficult time, as you say, getting through to the technician. So I could say, you know what, let's shorten that area a little bit, and then let's see what it looks like. When I place it in the patient's mouth, now I know what it's going to look like. If I put it in the patient's mouth and I know that it's going to be too long still, or not the shape I want, I can reduce it, I can make an impression of that, and that's going to be my guide for that ceramist to make those restorations exactly the way we want. Because in the olden days, a lot of times we prep the teeth, we say, hey, fabricate 6 veneers.
Right.
And what you got back is what you got back, because we didn't have the end in mind.
Exactly. So that's great. So the same technician who's doing the diagnostic wax up for you and is familiar with this case will be the same one designing the smile. Okay.
Exactly. And so as you can see, lateral view, we wanted to give him some canine guidance. We made the cusps a little bit longer than what they were before so that he would get lift off. So if he did grind, we were going to protect those teeth.
Okay.
And so you can see from the incisal. And so what I did is I placed that bisacryl in the wax, in the template, placed it over his teeth, and now I can just reduce where I want. So obviously if the teeth are, you know, in lingual version, when you put that depth cutter on, there's going to be very little reduction, maintaining all that enamel versus just putting a drill on, reducing everything 1/2 millimeter, which I think is an excellent way to do this.
And that's a really good point, because one of the services that DenMat Laboratory provides is something called the ART technique, which I already mentioned, the Additive-Reductive Template. And what it does is it takes those more complicated cases where a patient hasn't gone through orthodontics like this one, and you've got some teeth that are out to the facial and some to the lingual, and it's a series of templates that helps you know exactly where to reduce and by how much. In fact, let's go ahead and take a closer look at how these templates work in the mouth. The ART templates are a great way to know exactly how much to prepare and where to prepare on a veneer case. For example, we're looking at an arch here that was sent into the laboratory, and you can see we've got some definite rotations here. We know we're going to need to reduce in some areas, but exactly where does the technician need us to reduce and how much? And you can tell when this model comes back. So this is the color-coded model that comes back as part of the ART technique, and it's got a couple different colors of reduction on here. You can see these yellow areas. I'll point these out with the burr. These are areas where we're going to reduce with the template in place, and you'll see that in just a minute. Then you can see these orange demarcations, and these are areas where we're going to freehand some reduction without using the template. So typically this is going to be interproximally, opening a contact between two teeth. And that really frees up the technician a lot to change the width or even shift the midline on a case, and at the same time it allows the technician to wrap the ceramic veneer all the way back to the lingual, so we don't have the margin of the veneer coming meeting up with the tooth directly interproximally. So that's what those orange marks are for, is where the technician needs you to break the contacts. And then we can see a red reduction area here, and that's where the soft tissue needs to be recontoured. In fact, if we look at the initial model, you can see that papilla is just a little too fat between tooth number 7 and tooth number 8, so the technician would like you to take a diode laser and just narrow that papilla, and that's what the red marks are anytime you see that on one of these ART cases. So this is what the template itself looks like. If you remember, I mentioned that the template was anywhere we saw yellow, so those big facial surfaces where we need to do some reduction to be able to bring things into a more ideal arch form, and then you can see on some of the incisal edges and cusp tips as well that we have that yellow. So here's what the template looks like, and you simply seat this onto the patient's arch, and then using the burr of your choice, and they send a couple of burrs along if you're not sure which ones to use, you just reduce the tooth structure until the burr actually hits the green template itself. So here on that cuspid again is where we need all that reduction, and we're just going to flatten that off till it's in plane with the template itself. You can see that we've got some reduction on this cusp tip and the cusp tips over here as well. And so this is the technician being able to tell you exactly where to reduce to be able to get the aesthetic result that you're looking for. So once you've done all this reduction in the patient's mouth, we go to the final step, which is a clear mold of the diagnostic wax-up that you and the patient agreed to. That was the smile that they wanted to have. And so they take that smile, that wax-up, and they make this clear polyvinyl siloxane template that fits over that. And so you take the included material, the Perfect Temp 10, which is their bisacryl material. A2 works in most cases, but you could certainly use an A1. And you fill the bisacryl into the trial smile template and then seat this onto the patient's prep teeth. The excess squirts out above into the vestibule, and you just wait and you lock that on to the patient's teeth. And it's a nice, tight, intimate fit around the gingival margin. So when you take the Trial Smile template off, you can just break off the excess bisacryl material and then smooth any area. So what you've done is you've taken the diagnostic wax up and transferred it from the model into the patient's mouth. So this is their Trial Smile, and this is what their veneers are going to look like unless they have any changes. So if you want to go in and soften the cuss tips in a couple areas, feel free. Just take an impression of that and send it to the laboratory. So you can see through the use of the ART templates and the guide to show you where you need to do a little freehand reduction. This takes all the guessing out of these cases. So no more prep and pray. We're intelligently prepping to get our best cosmetic result. Okay, so back to the case, Bob. So we're getting ready. We're going to prepare it right through that bisacryl that you put on the tooth. And once the preparation's done, you're going to use that same matrix to go ahead and put the temporaries on the tooth.
Exactly.
So let's see what that looks like.
So we place the temporaries and we decide, is this what we want? Obviously, you know, if we don't like that, we're going to have to change it.
Right.
And then we're going to let the patient leave. We're going to make an impression, send it to the laboratory, and we say, copy this. And you're going to get back restorations that are going to fit precisely into that wax up.
So this is a Trial Smile. So in effect, when the patient leaves on the prep date, what they see in their mouth and what they're going to be able to live with for the next couple of weeks is what the restorations are going to look like. So if you didn't make any changes to that, the DenMat lab already has designed it digitally and has that file. But like you said, if you go in and make changes to the incisal edge length or recontour a cuspid or something, you can take a new impression, send it to them, they'll pour a model and scan it, and then use that to digitally design your final restoration.
I think the value here is that if you're starting out and you're doing veneers and you're not sure where to reduce, I think is a very added benefit, because we didn't have that luxury back then. You know, and I see cases that I did 25 years ago. They're still in the mouth, maybe not as aesthetic, but because we didn't reduce enough or we didn't know exactly where to reduce that.
There's a reason we used to call it prep and pray, because we didn't know what it was going to look like when it was all done. And frankly, as a dentist, it made it harder to sell these cases, quote unquote, to tell a patient with the utmost confidence this is going to look great, because we really didn't know what it was going to look like. In fact, the DenMat laboratory has an imaging service where you can take a picture of your patient, send it into them, they'll image the smile and send it back so you can show it to them. That just ties into the whole predictability and consistency of this technique. Let's take a look at the final picture real quick and see what you think about that. How'd the case turn out?
Patient was very, very happy with it. And you and I both know we have a certain style that we like. Maybe we want to have surface texture, maybe we want to have incisal translucency. So I think it's important to show patients what they may want to look like, because some may say, you know, I don't want that incisal translucency. And to be able to talk to the technician and tell them exactly what you want one-on-one is very important to me, because sometimes it gets lost in the dialogue, and then you get something that you like but the patient doesn't like. You know, overall the patient was very, very happy with the final result, and that's what's the most important thing to me, because it's what the patient wants, not what we want. And I will tell you this, that as we talked about with the provisionalization, back in the day, I didn't use provisionals a lot. Why? Because we were prepping in the enamel and we'd say, make the veneers, and you got the veneer that you got. And that was it. And that was that. You had to cross your fingers and hope for the best. I spent 15 years inside of a large dental laboratory, and I saw firsthand that for most laboratories, 80% of the work that comes in are posterior units, and then maybe 20% is anterior units. The DenMat laboratory is interesting in that 85, almost 90% of the work they do is anterior units, and then the rest is posterior. Do you find value using a laboratory that focuses so much on anterior restorations? Yeah, I do, and I think it's important because a lot of times the experience that they bring to the case really helps you, especially with the knowledge over the last 30, 35 years. They've made the mistakes, they've corrected what they want to do, and I think it gives you a little bit more sense of security. And I think that using an anterior lab for some cases and a posterior is perfectly normal. And I think a lot of dentists use different labs for their different specialty type restoration. Exactly, and I think that's a very common sense way to do it. Well, as always, thank you for spending a little time with us. I love being able to pick your brain. That'll wrap it up for this edition of Inside Dentistry's Product Talk. On behalf of myself and everybody at Inside Dentistry, including the editor-in-chief, I want to thank you for your time and your continued commitment to quality dentistry.